Good morning and good afternoon. Welcome to today's webinar, Prior Authorization Regulation, Fact, Future, and Changes for Patients, Providers, and Payers. My name is Phil Dolan. I'm Chief Growth Officer at Valor. We're a provider of automation technology that speeds and simplifies prior authorization management. Before we get underway today, I'll share a few housekeeping notes. First, today's webinar is designed to keep you current on today's prior authorization legislation landscape, the outlook ahead and what it means for you. There's no product demo today. If you have interest in Valor's prior authorization automation solution, you can request follow-up in the survey that you'll receive at the end of today's webinar. Even if you're not looking for help with prior authorization management, we'd love your feedback on today's webinar. Survey respondents will be entered in a drawing for a $100 Amazon gift card, and we'll let you know who won our drawing in our follow-up email next week. We invite your questions throughout today's webinar, and we'll address as many as we can at the end. Please use the Q&A button at the bottom of your screen. If we don't have time to address your questions today, we'll address your questions following today's webinar with the email address that you provide us with your survey. You may also use the chat button if you want to share any thoughts with other attendees or our panelists today. Finally, we'll be recording today's webinar, and we'll make that recording available to you next week. Again, look for our email at that time. Now I'd like to introduce you to today's speakers. First is Dr. Steve Kim, who's co-founder and CEO at Valor, a provider of solutions that automate prior authorization and referral management. With more than 20 years of medical experience and a passion for studying value-based care outcomes, Steve's expertise has been vital in navigating the evolving complexities of the healthcare industry and identifying the administrative roadblocks and bottlenecks delaying access to care. Before his transition into entrepreneurship, Steve was an assistant professor of urology at the University of Southern California's Keck School of Medicine. And while at Keck, Steve also served as the director of clinical research for the Children's Hospital, Los Angeles, in addition to practicing pediatric urology. Steve earned his undergraduate degree at Yale University and was awarded his medical degree from Cornell Medical College. Michelle Person-Madison is a partner in the healthcare practice at Morris, Manning & Martin, where she provides general legal advice to health systems in various regulatory and business matters. Michelle also works with information technology companies and advises clients on compliance with regulations and industry standards. She has specific experience in negotiating contractual agreements between healthcare providers and service providers, interpreting and advising health systems on regulations applicable to the healthcare industry, and provides regulatory advice with a focus on Stark, anti-kickback, and HIPAA. Michelle also provides advice for compliance with state and federal regulations and regularly drafts and negotiates agreements with hospitals, physicians, managed care organizations, and ancillary service providers, as well as contractual agreements for vendors with an emphasis on information technology, purchasing, and lease agreements. Tim Holland is an accomplished revenue cycle and patient access leader with almost 20 years of experience in the field. He served on the board of directors for the National Association of Healthcare Access Management and has worked in multiple large healthcare systems across the country in various operational leadership and consulting roles. He has a great passion for improving both a patient's customer and financial experience with their chosen health system and truly finds joy in identifying and optimizing operational processes within referral management, patient scheduling, patient estimates, collection practices, denial management, and operational leadership. Tim is a proud husband and father of 3. Tim spends most of his free time making memories with his family, serving his local community through volunteering with local nonprofits, leading or co-leading recreational sports programs, and traveling as much as possible. I like that, Tim. Finally, last but not least, is Evan Martin. Evan is the Director of Advisory Services at the Wilshire Group and is the Oregon chapter of HFMA's president-elect. Evan brings a wealth of revenue cycle and revenue integrity operational experience. His unique background allows him to work seamlessly with clinical operations, information services, and revenue cycle leaders. As a former revenue cycle director, Evan supported various divisions with an extensive background in revenue integrity, denial prevention, and new program development. Evan has supported 53 Epic implementations, with designing system functionality to providing at-the-elbow training and support to clinical operations. Evan also applies his Six Sigma training to process improvement engagements. His efforts resulted in reduced revenue leakage and improved financial outcomes for the organizations with whom he's worked. Evan is co-producing and co-hosting the Wilshire IT Revcast, a new bite-sized podcast series which features fresh outlooks addressing the most pressing issues and opportunities facing the revenue cycle management and revenue cycle IT space. Evan is an active member of the Oregon chapter of HFMA, currently the Security of Oregon chapter, and on several Western Region Symposium committees. From here, Steve, I'll ask you to take it away.
Thank you, Phil, and thank you to everybody for joining us for today's webinar on prior authorization regulation. Certainly want to get an extra special thank you to our guest panelists, Michelle, Evan, and Tim, for their willingness to share their insights, their perspectives, and their expertise when it comes to prior authorizations. To provide a little bit of background, as Phil mentioned, I'm a pediatric surgeon by background and training, and prior authorizations were something that I faced and struggled on a daily basis, and my staff had to deal with heavy administrative burdens to get that done. Most importantly to me and for many of the providers is really about patient outcomes and the impact that prior authorizations have been having when it comes to delays in therapy, denied therapy, and unfortunate adverse outcomes that happen from prior authorizations. For those of you who may not be as familiar with prior authorizations, I tell people it's a permission slip. As a provider, I've had to fill out permission slips from the insurance companies to get approval, but also to get paid for the services that I wanted to deliver and treat. Prior authorizations, when they first started, have really kind of started out in order to protect patients from what was deemed to be medically unnecessary services and procedures back in the day. But over the past several years, it's really transformed and morphed into a cost containment strategy implemented and used by health payers and plans. There's been a lot of activation and energy around prior authorizations due to the frustrations that providers and patients have felt when it comes to prior authorizations. The American Medical Association, or the AMA, has had a notable campaign over the past several years called the #FixPriorAuth movement, which has also come with prior authorization reform being one of the top agendas and activities from a lobbying and legislative perspective when it comes to reforming some of the painful challenges when it comes to prior auths. As a result of this, we're starting to see the fruit of that lobbying efforts kind of come to bear with a significant amount of legislative and regulatory actions that are coming, both at the state level and the federal level. I think as someone who speaks to people every day about prior authorizations, increasingly become a topic of what is going on with regulation. So we may not have all the answers on this short webinar. It's still the very early innings when it comes to prior authorization regulation and understanding what does this mean. Many of these rules have not been actually enforced or enforced yet. But what we're hoping to do with this conversation is to really start stimulating further conversations and discussions about prior authorization regulations, because it's something that will continue to evolve and dynamically change over time. So we thank you for participating. Hopefully have some questions that we can address at the end of the session. But really to kick it off, I'm going to turn it over to Michelle to maybe give us a little bit of a background of what's actually been happening out there when it comes both to state-based legislation as well as the most recent federal legislation as it pertains to prior authorizations. Michelle, do you mind taking it from there?
Sure, I'm happy to. Thank you, Steve. And hello, everyone. Thank you for letting me share some of this information with you all, and we look forward to the discussion. This has been a hot topic. The AMA has identified that there are 9 states that have already passed pretty comprehensive prior authorization legislation. But when you actually look at the number of bills that they cited in March of this year, there were 90 bills working through 30 states. So that's a pretty extensive legislative initiative across the United States. And of course, each state has something that's always a little bit different. But even if you look today, before those 90 bills are completed and passed, a lot of states, and when I say a lot, the majority of the states, have some kind of provision about prior authorization, whether it's you need to respond within this period of time from a payer perspective, or usually in the payer policies and procedures, it'll say what timing the provider must request the prior authorization, to who has to be the individual who reviews the prior authorization and makes that determination, to whether or not there are certain data points that states will require to be looked at. And then what are the exceptions? So if I get a prior authorization in a certain state, and can I rely on that? Or is it possible that I'm going to get a retroactive denial? So even though we've got 9 states that passed comprehensive laws, we still have many states that already have bills on their books today that impact those different data points. And I think what's really heightened our awareness, I think, in this last 6 months is CMS did finalize their rule about prior authorization, and that was finalized in January of this year. But I'm going to take you back a little bit because when CMS finalized it, they finalized it inside of the interoperability final rule. So I'm going to take you back to 2009 when we had the American Recovery and Reinvestment Act. And as providers, we were receiving financial incentives to change our behavior and electronically adopt or implement certified electronic health records. And that has moved us through the industry since 2009 forward, as we've reported on meaningful use and we've reported on MIPS metrics, to change our behavior of what we electronically exchange. And what CMS said was, we are going to drive this interoperability. And one of the areas where we feel like payers and patients and providers need to all electronically communicate is about prior authorizations, because it is a critical component of both cost containment, revenue cycle management on the provider side, and patients being concerned about their responsibility for payment if that prior authorization is not there. So it impacts all 3 legs of the healthcare stool. So we have to look at what CMS decided. And what they said was, and there are multiple provisions inside this final rule in January, it's like 257 pages of lovely regulations. So, but if you look at the rule related to prior authorization, they focused on 2 different things. One was really just the elements of prior authorization and the timing and response. So CMS is saying for Medicare Advantage plans, for Medicaid plans, for the children's health insurance programs, and for some qualified health plans, if they arise after January of 2026 or 2027, they'll be in this as well. But right now, it's more Medicare Advantage, state Medicaid, and the CHIP programs. And they will require, from a CMS perspective, starting in January of 2026, for there to be a response to a prior authorization for urgent matters within 72 hours, and then for non-urgent matters within 7 calendar days. So CMS is setting a time frame. And if you went and looked at the state laws on some of the books today, you'll see something similar. There'll be a urgent time period you've got to respond. Sometimes that's 1 day, sometimes it's 3 days, sometimes it's 7 days. And then there will be a non-urgent time period, which I've seen range anywhere from 3 days to 15 days to 18 days. It just depends on the state that you're in. But from a Medicare or CMS perspective, 72 hours on urgent, 7 days on non-urgent. And they also want the payers to really identify the reason why something may have been denied and also outline that appeal process. So remember, when we started doing electronic exchange of information, one of the key words we hear every single time we talk about it is transparency. And so CMS is looking for that transparency between payers and providers of, okay, we got your prior authorization. This is our decision, and here's why we made this decision. So that's an important part. They also want the payers to, and for the, well, for the payers to really start collecting data about the prior authorization. So start looking at what percentage of the requests were actually approved, how many were denied, how many were approved after appeal, and then what was that submission time period? So if we went outside of that time period, what does that look like? So those kind of data points are going to be used in the future to set more comprehensive laws, is what I would speculate and project. Because whenever CMS says we want you to report on these things, that typically goes into a study report and we'll get an updated amended rule at a later date. Now in 2027, those same health plans will go from not just making decisions in that time frame, but electronically exchanging it on an API. So there will be a prior authorization API that will be a requirement for those types of plans, Medicare Advantage, Medicaid, CHIP, and that'll happen in January of 2027. And CMS has been very expressive about the fact that they're giving this time period to allow ample time to be able to develop the technical interchanges so that the data can be exchanged and there can be a meaningful discussion between payers, providers, and patients. So it's a hot topic from a legislative perspective. I think CMS amplified that with this final rule that came out in January. And as we go through the legislative sessions in the state, I think this will be an area of focus throughout this year. And then for a lot of states, they go back into session in early January. And I think this will be an area of topic throughout the United States.
Yeah, thank you for that background overview. And as I understand it, the initial emphasis from the CMS final rule really is more focused at the payer level, both the requirement for developing APIs, but there's some things that are actually added in there that I think around the MIPS requirement, where as providers, we're all very familiar with some of the certification process, but there is a passage, I believe, that may reflect some of what we're expected to do on the provider side to certify. Is that correct?
Absolutely. So you can't miss a chance to add something to MIPS. So in 2027, then there will be a requirement. And what they're going to do is set up a MIPS promoting interoperability performance category that's going to be directly related to prior authorization measures. So there'll be yes or no measures, and you'll get measured on that. And remember, this impacts the provider's reimbursement under Medicare. So you're either eligible for that increase or there's a lower payment that gets applied if you don't report on those MIPS metrics. So yes, and that tool of MIPS, in my mind as an attorney, is a behavioral change. So it's getting us into the habit of I'm reporting on this, so I'm engaging in this with my staff in my office, and then that becomes more of the culture and the behavior that we engage in moving forward.
And certainly there was a lot in there that you talked about that as a provider, very much interested on the provider side in terms of timely turnaround responses for sure. There's been a lot of conversations about gold carding as of late. I think the Texas state legislature passed that a year and a half ago, roughly. Can you maybe just kind of talk about what that means for folks and kind of what it's intended to do in terms of the gold carding process?
I think it's fascinating. So there are a couple of states that have that gold carding, and Tim and Evan can add much more detail to it. So I'll give the high level and then let them speak to the details. But the concept in Texas is if I'm a provider and I have a 90% approval rate, I get my gold card and I'm exempt from prior authorization, but it's related to very specific items and services. So I think from a logistical and operational standpoint, there's a lot to unpack related to gold carding and how that works. So I'll stop talking and let Tim and Evan kind of chime in on that, if that's okay.
That's certainly my
so
provider. Go ahead, Tim, please.
Gold carding is great in concept. I haven't seen a lot of organizations really implement too much of it yet, both from the provider side or the payer side. The data really, from an authorization perspective, most of that is going to live on the payer side in terms of like how effective they are in terms of which providers are getting that 90% threshold and which ones are not. And you really have to have a very strong team from the provider perspective to be able to interact with the payer, identify which providers would really fall into that particular category, and then based off of that, set up infrastructure and workflows and processes on the provider side to make sure that you're getting those authorizations. I think that it's very promising. I'm really excited to see where it goes, but gold card is relatively new still, and you just haven't seen too much movement there in terms of what is actually happening.
Yeah,
I think the part that they failed to figure out though is around procedures that modify. So it's about, was it approved, and then did that procedure actually maintain going forward for that denial component, and being able to modify our managed care contracts associated with commercial payers to implement that gold card component. That's portion of it, right? We got to go through the negotiation process and and say, hey, we're taking out this language about what maybe already addressed prior auth, and we're going to now go and rectify with state legislation around gold carding components for these specific services that they outline. And then how do you now, to Tim's point, measure it, but also, if in that service, if you had X and now Y actually performed when you got in there, how do we, that affects your gold carding rating, or does it? And that's the portion that the legislation doesn't really call out. So that's the part you have to know. We as partners with our managed care counterparts on the insurance side, and with our managed care contracting counterparts within our health systems, is from a revenue cycle side, is bringing all three of us coming together and really having that conversation about what are those going to be those key KPIs that we're going to measure within that gold carding process to hit that 90, what we're identifying as 90%, because it speaks to 90%, but it doesn't really call out the other elements that we know take place in our general operations.
Completely agree.
Following up on that question, as a provider, it's just how do you keep tabs and track of everything, right? Because it's really retrospective and learning, seeing what has happened in the past 6 months or 9 months, depending on which state it is. And I think that puts another level of administrative burden on how you actually track it, how do you measure it, and it's a little bit of a cycle over depending on what legislation has. So how do you determine who gets a card? A lot of typical workflow implementation questions that still have to get answered, and certainly even if you've got any thoughts around some of the implications in enacting gold card.
So sorry, Steve, but I think you cut out the very last bit of that. Could you repeat that one more time?
Apologize for having audio issues. Just wanted to see if maybe you may comment on the practical work implications of actually enacting any sort of gold card process and getting the data.
Yeah, so I would say that the payers will have, a lot of that data more readily available, in terms of like which providers are submitting for what types of authorizations and what procedures. So it's going to be a little bit easier to kind of capture and report upon from that perspective. But that's not to say that the providers can't do it themselves. I've seen a couple of different clients that I've personally worked with where we've been able to track specific data points in terms of when we're submitting an authorization, when we're actually getting responses back from that, and what the success rate is of that particular auth. And you can get down to that particular level. It's easier for certain EMRs versus others. So if you have an electric EMR, like say for Epic or Cerner or something, they have typically pretty robust reporting capabilities. I know that there's some bolt-on vendors that kind of help with that, Valor included. They can kind of help report on a lot of that information and then help the provider go back and have that negotiating or that conversation with a particular payer to kind of help come to an agreed upon state in terms of what procedures need to follow in a gold card and which ones can.
Absolutely. I think there will be a need for better data on the provider side as well to kind of help enforcement of that. And that's certainly something that we've been looking at Valor. Another thing that comes up quite often in discussions that I have, and maybe I'll maybe turn this to Evan in terms of some of the confusion out there about, the application of all the different regulations and how do you start kind of keeping track and understanding. Can you maybe talk a little about some examples that you might have seen and talk a little bit about that?
Yeah, I think it definitely comes into play. Who's on point, who's on second really is the conversation, right? Like, is it going to be the federal regulation? Is it going to be your state? Who's the governing body over those different entities and gets to have that rule and say? And I think where it becomes more complex is as we're starting to see more and more health systems, whether it's one hospital in another state that they're managing and running versus, multi-states where some are in like 3 or 4 different states or across the nation, leveraging our systems and our processes to address each of those states' regulations, or are you addressing to the highest regulated concern as well? And how are you going to convert your system? And I think that's really where a lot of confusion comes into play, is knowing when you have a denial and you know from your contract language or that state legislation language, or even now the federal legislation, who do you go to for that support if you've exhausted all of your denial benefit component, right? And all your appeal processes and everything. And I think that's where sometimes we struggle as operational leaders, is saying, okay, if it's Medicare and managed Medicare and Medicaid lines of business, do we look to the federal legislation, or do we look to the state legislation if it's a higher threshold? And really, a lot of it is that federal legislation for that component. But when we're looking at the commercial payers, really look to your state legislation to see what they're calling out. Not that the federal government can't implement requirements for commercial payers, as we've seen through like pricing transparency in other areas, but usually your higher regulation will be more state specific, where then you're going to the insurance commissioner of your state and through the attorney general's office and things of that nature for support. So that's really where you want to dissect. And you will have to, if you are a multi-state health system, you are going to have to figure out, how do you carve out your systems through your EMR and with your partnerships in technology to address those differences for those specific state requirements. I think what also lays in it, as we know, many national health plans are leveraging more states. So you could have health plan X that is based in Washington, and yet the patient is visiting in Nebraska, and they're leveraging that contract with their sister plan at that to leverage contract and network benefits and all of that. So the question is are they regulated under Nebraska because that's where services were rendered, or are they really are they regulated under Washington? And I think that's what causes a lot of us confusion as operations, is the plan. We've seen plans sometimes point us back to the home plan, but they're leveraging our contract terms within. So I think that's where we really have to partner with our internal legal teams, partner with firms like Michelle's team and stuff, to get some of that legislation and legal guidance on who actually is on point for being on the hook of processing the claim appropriately.
Yeah, and Steve, I can chime in here if that's okay. From a state to state perspective, so CMS is going to govern the impacted plans from its final rule. But when we go from state to state, I see that in two ways, of kind of a logistical issue of, all right, I'm a hospital and I have facilities in two different states. I'm accepting payment from two different payers. They're both registered at the state level with the Office of the Insurance Commissioner or the Department of Insurance, whichever the state calls it. And so my state A doesn't govern state B, and state B doesn't govern state A. And so if you get to the point where you're issuing a complaint, you're going to the state that has governance over the individual who's licensed in that state. So the contract language is really important, because sometimes you'll have state A's plan have a reciprocity provision to be able to access state B's contract for that provider. Not always, but sometimes you do. And so you really have to spell out, okay, well, from a governance perspective, we're accessing this contract, but that payer plan is regulated and licensed in a different state. And does the contract specify which route I have to go if I go to an agency? And then which of these provisions do I have to comply with? Because one state may have a prior authorization saying you have to give approval in 24 hours, and one might say 5 days. And so the contract language, I think, is very important. And sometimes you can't contract outside of the state law, right? It's going to be whichever is, if the state law says it has to be 5 days and your contract says no less than 2 days, then more than likely your contract's going to be enforceable because it's less than the state requirement. But if it goes beyond that, is it enforceable because it doesn't necessarily comply? And I have seen contracts that don't necessarily comply with the state provisions, but the parties have negotiated at arm's length and they've enforced it as a contract issue and not a state agency or licensure issue. So as an attorney, when I look at it, I think about it three different ways, but it's all related back to my contract. I need to look and see where my facilities are. I need to see what kind of payer I'm negotiating with. Are they licensed in the state, or are they outside of the state parameters? And then what is my dispute resolution process? Because most of these have arbitration or mediation. And then what's the next step after that? Is it binding, or can I go to a state agency? Because a lot of times state agencies will say, we don't necessarily deal in contract issues. So my advice as an attorney is, as you're negotiating that payer agreement up front, to have that conversation with the payer so that you both have the same expectation of what the requirements are. So you're not thinking they're going to respond in 2 days and they respond in 5, because that's their state. And then secondly, you can have an exhibit that can be amended with what you think the requirements are as the state laws modify, because we're at the height of all these bills. Things are going to get amended over time, and it's easier to amend an amendment or an exhibit than it is to amend the entire payer agreement. So that's my long way of saying there are different avenues you can go, but a lot of it comes down to what did you discuss and negotiate in a mutual meeting of the minds with the payer.
Yeah, in many ways, like prior authorizations themselves, because they're so hyper fragmented, that in some ways, although well intentioned, all the legislative activity in its own right is creating confusion. All right, so just trying to understand how to manage all the different regulations and what rules apply, I think, will be a fundamental workflow challenge for all of us on the provider side. And so certainly, maybe not fully thought into some of the conversations when legislation was passed, but something we're going to have to address and continue to talk about doing. All this legislative activity was intended to show benefit, right, to alleviate the administrative burden. And certainly from the patient side of the equation, it makes pretty clear sense, obviously, in timely turnarounds and getting the the authorizations approved for services. And I know, Tim, you talked a little bit about some of the benefits around the gold carding, the intentions there. Evan, would you mind maybe talking about some of the benefits that, or the impact that, the regulation might have on revenue cycle, vendors, and kind of just the processes in general?
Yeah, I think from definitely from a revenue cycle perspective, right? When we step back and look at um, our EMR and EHR systems, how are we leveraging that technology that is through there? And then if you are even as a vendor perspective, you're servicing 50 different states with potentially 50 different regulations plus CMS, and we're having to convert and configure our platforms to help with those workflows and address each of those individual state requirements. And then you throw the complexity of what are your contract terms, to Michelle's point of, how do we now manage those complexities? Because while we're all trying to streamline processes and make it easier and quicker for the patient to receive care, and we are too, we're also trying to make sure that we're addressing the concerns around, is this the right care at the right time for that patient to be receiving? And that's really where I think as a technology provider, we have to be more open, and we need them to be more open. Wilshire doesn't offer that, but like from our perspective of like, we need our technology providers to be more open to hearing the fluidness of the state and thinking through like, okay, even if we don't offer this, who does offer something that's more targeted to your state that's going to be able to support you or support your organization with that? And it sometimes does mean you leverage some business partners for a subset of services because they're experts in that component of legislation. Going back to gold carding, for instance, it's a subset of services that were approved as being part of that. So there might be an awesome vendor out on the market that you want to partner with operationally, and they've solved that part. But we really have to start to evaluate from an operational perspective and revenue cycle, which business partners, how do we engage, and how are they staying up on not only the federal requirements, but the state requirements as well to help address. And I think that's, as business partners, that's where we struggle, even from a consulting perspective. I know, Tim and I have both had clients where we've had to operate in Maryland and also operate in a state that's not in Maryland at the same time. And those legislations are completely different. And even from California to Oregon is completely different in that regards, but they're all on the West Coast, and you would think that they would be a little closer together, right? And like their mindset and processing. So I think it really does lend this struggle for us to stay ahead of it, but really need to partner on how do we address it and hear clients and customers feedback on both the provider, but also on the plan side of the house too, because what we're sending or how we're communicating with them, is it going to help with their workflows? Because it's really intended to streamline the process for both sides of the house. But really, we put a lot of emphasis on focusing on one versus pulling that partnership together to say, okay, if we implement this, how's that going to affect you? How's that going to affect us? Does that really meet the requirement for us?
Yeah, I couldn't agree with you more in terms of the need for a lot of conversations and discussions, because it does impact everybody on all sides of the equation. Certainly from a patient access perspective, Tim, I know that this, will have some ripples and impact on kind of, how you think about structuring and organizing your teams. Can you talk about maybe some of the impact there that you might anticipate or see related to some of the legislation?
Yep. Yeah, I'm a very big advocate of central financial clearance and authorization, just because of the ability to standardize and stage things a little better. In terms of how I think this legislation is going to influence the structure of that, in some ways where you see, authorizations become a little easier, or in Gold Carding's case, not necessary, you can then begin to look at restructuring teams or reducing the overall size of teams, which is going to be overall labor savings, for an organization, which I think is going to be beneficial. I think that in other cases where you're going to, like to Evan's point a little earlier, where you might authorize for service A, but service B was solely performed, it may be kind of a redesign in terms of what the clearance team is responsible for doing, to where you're having to go back and work on an appeal versus working on initial financial authorization of clearance that you're having to do. So you're going to have to make sure you're considering a number of those types of factors. I'd also encourage that if you have a central team or are considering to creating a central team, that you make sure you're monitoring appropriate data points and KPIs, to make sure that your team is both being productive and to give you the necessary information to go back and have conversations with payers or providers when things are not exactly lining up how you would expect them to line up. Different, authorization resolution rate, necessity rates, authorization denial rates, both from a pre-service denial and post-service denial, if you have that type of case change. Getting a little more granular, looking at data points where, when did we schedule the date of service? When did we initiate the authorization? When did we complete the authorization? Having a lot of that information available is going to help you design and structure a very effective financial clearance team long term. So I think the legislation is going to help in some ways. I think that there's also some question marks out there that we just don't know yet, because we don't have the specifics of certain pieces of legislation. But all in all, I think it's a beneficial, especially for centralized or more structured type teams.
Yeah, absolutely. And I think, we've been in conversations about the NAHAM metrics that they've been developing around looking to kind of quantify that. I think there'll be a large emphasis and need for data, really, and transparency to be able to enforce and compliance, right? So those are some of the will be critical. And I think, as people kind of understand and process what the needs are to help support that, it's about transparency. It's about collecting data to have that conversation right back and forth. So there'll be some opportunities to continue to understand how to better collect that data. Evan, just, we talk a lot about the denial rates and just any sort of impact on denials and reductions. I know that's a huge part of what happens to health systems, to practices. Maybe some thoughts and implications about what this may mean around that process.
Yeah, I think for straightforward authorizations, that service A what is being authorized and service B is what is actually being performed, and service A is what's being performed, makes perfect sense, right? Like if I'm getting an auth for a total knee and the provider did a total knee and everything went according to plan, we do hope to see denial reduction, especially like even when the gold carding component of where, if the provider always is doing that same routine service, it's just going to go through. Where we still have not seen legislation actually address anything is around the the medical necessity change. So what we believed we were going to do when from a provider perspective and went in to go do that service, and what actually ended up resulting in it, if those additional codes weren't prior auth, then that's where we're going to get a denial. So for instance, I just was reviewing a case. We thought we were actually going to go in and do a GI procedure that was not just routine GI, with some stretching, additional stretching codes, and the method was approved and everything. The provider went to go do it, ended up having to do the same procedure, but use a different method in which they were doing it. And that resulted in a denial. And that's where, we don't have legislation yet, or the lobbyists partnering with us yet, to really get to that point of how do we remove that red tape to say, if it's in the same family of codes and maybe the approach had to modify, or if it had to go from a partial to a total, or it was going in to do a routine and you end up having to do a biopsy with it. All of that additional red tape of causing a denial, which causes administrative overhead for both sides, hasn't been addressed yet in the prior auth portion. So while our legislation is really trying to get faster care to our patients currently, which is great and what we need, it's still not addressing that administrative overhead that's really still causing that additional cost back to everybody and rising the increase of healthcare. So I think that will be future state phases of what we probably start to see with some of the prior auth, or around prior auth, and some legislation that we'll see some states start to probably tackle before the feds fully tackle it. But in that regards, I think, we're going to see some improvement with the legislation, but we're not going to see a ton of improvement right out of the gate.
Yeah, I certainly agree with you on some of those. There have been attempts from other states to just say for blanket chronic conditions, it has to be good for a year, and certainly an advocate of that for some of the changes that may happen. But I think clearly there are going to be a lot of actual, rubber hits the road details that are still not addressed in any of the legislation that I've certainly seen. There's some components that reflect it. I think this is really a starting point. But still a lot of work still be done. And Michelle, I don't know if you've encountered any of those types of things cropping up in some of the legislative efforts that you've seen.
Yeah, I mean, even if you just look at the CMS, when they talk about the API that's going to come out, so the elements that go into that API are what's the prior authorization status, when was it requested, when does it end, and what's the description of the items and services. And then also what quantity has been used. So if it's they normally don't do the drug side, but the quantity of, let's say therapy got a prior authorization and now they've had it for 30 days and the prior authorization's expired. Where I see, to the point that they were making earlier, is when that item or service differs when you actually get in to do the service. I think that's a huge risk area for our providers, because you have to render the care that's medically necessary at the time you're in that procedure. And yet our prior authorization didn't have that CPT code or that description in there. And I do see a lot of audits and appeals today at a state level and at a federal level because of that differentiation between what I had a PA for versus this is what I found when I went into the procedure. And that's a hard one. The other big thing is a lot of people are focused on, okay, if I get the prior authorization, then no one should ever be able to come back and retroactively take back the dollars. And today there are states, and even in the ABA's model agreement, where the ABA put out a model description of what a prior authorization law could look like back in 2022. And they even had exceptions, which is what I normally see at the state level. Things like, yes, you got a prior authorization, but lo and behold, after we gave you the prior authorization, we learned that they weren't actually on our insurance plan. They never paid their premium, or that was never a covered service for us. And so it winds up being one of those little exception areas where somebody can come back retroactively. So I think that's a big area that I'm seeing at a state level of where are the carve outs. If you do get a prior authorization, where's the potential that somebody could come back retroactively? There are some of them that say, if you get a prior authorization, you are good to go unless, there's fraud, something really high level that would stop it. So depending upon what state you're in, that will differ. The part about the continuum of care, the model is for 90 days for the model of the care is for 45 days. But then if I go from one insurance plan to another insurance plan, then they will accept my prior authorization at the first insurance plan under the model plan. This isn't the same in all states, for 90 days. So that gives them time to look at it and decide under the new plan, should I continue? And then chronic care, of course, is for that year term. So I think as we move forward in kind of fleshing out these regs that are coming down, and especially when we do the API and what elements go into it, I think we will see a focus on the continuum of care. How do we address it when items and services actually differ for medical necessity reasons? And then how do we address the continuum of care when a patient goes from one payer to another, or they have a chronic disease, or is there some presumption that if I got a prior authorization, then it should be good for X period of time? And I think the timing elements of a prior authorization obviously hold the day, but I think that we will get more information as we move forward and more regs become final, if that makes sense.
No, it absolutely does. I think there's a lot to unpack around how does this actually practically get implemented. I think right now the CMS final rule really addresses kind of what the payers are going to be responsible for providing as the first couple of passes. We at Valor are very much involved in discussions around the next set of APIs of actually how do we turn this into an API-based delivery for all the financial and clinical information back and forth to the other parts of the prior authorization workflow. And there's certainly a lot of potential workflow challenges there to work through as well. So I wanted to maybe now kind of switch over to maybe some bits of advice or best practices, or maybe just some little pearls of wisdom that each of you might be able to provide from your perspectives that people should think about as they start sitting down to process and think about how they're going to work through some of the legislative and regulatory trends that are happening. And maybe we'll start with Evan. Do you want to maybe give some advice for folks on the webinar?
Yeah, I think I would first, as individually as you guys look at it, I think, pulling in your teams to say this, first get clarity from your leadership, from legal and your in-house corporate compliance teams of like what their interpretation of the regs and everything are. But I think then go to your actual team and say, okay, how are we going to impact this? How are we going to do that? And then I'm a huge proponent of leveraging your national associations as well. Reach out to your local chapters of HFMA or NAHAM. I think being able to see what your peers are doing and how they're managing it, talk through which EMR systems you're on. And then if you are on an EMR, put in a service ticket with that vendor and see what are they doing to help build out and address it as well from their EMR capability. And if they come back and say we're not, then target it to who your business partner is today. That would be my first step of kind of engagement of peers to see how are they going to get the conversation talking. It's better to do it as a group than it is to try to solve it in a silo.
Absolutely. I think part of the webinar here is intended to kind of stimulate more discussion, because I think there's a lot of this that needs to get done as we start understanding what the evolving landscape is. Tim, do you have any kind of advice or guidance or pearls that you might leave for the audience?
Yeah, there's a few. I mean, we had a good bit of conversation around when we have situations where we're authorizing one procedure, but we end up performing another, or and I've seen two different successful strategies to really kind of alleviate that from the operations or the provider side. One is to see if you can get your payer to agree to authorizing a bundle of codes at a single time. So if you're coming in and you're like, you're doing a exploratory abdominal surgery, but while you're in surgery, you happen to find X, Y, and Z or something like that. That's a very broad example, but just related codes, authorizing related codes when you do something like that. That will not necessarily prevent all denials on the back end, but it should have a bit of a reduction to kind of help you better manage what remains. From the other side, when and if you get those post-service denials, you're having to go through the retro authorization process. See if you can't negotiate with your payers to extend the amount of time that you have to submit the retro authorization, because that can differ from payer to payer, right? If you have 24 hours for Aetna, but you have 48 hours for Blue or something like that, that can be very difficult to manage operationally speaking. So if you're able to negotiate at least some sort of standardized metric, from the payer side. And then operationally, if you're able to go in and put a process in place to say you have to have these retro auths completed and out the door within X amount of time, between the two sides of that, you should be able to have somewhat of a more complete or robust clearance process or retro authorization process after the fact. So just two little pearls of wisdom, things I've seen that have been very successful in other organizations that I've worked with it for. Happy to take any other questions if you have some.
Yeah, that's great. I think always good to share what could be best practices. And to Evan's point, we're all here to kind of learn together. Michelle, maybe I'll leave you with the position to kind of leave with the final words of wisdom around legislation and regulatory efforts and advice.
Yeah, so if I put on my payer hat, I think I'm looking at what types of services do we require for prior authorization, and then from an IT perspective, are we able to relay the reason for the denial and also make sure we're satisfying the transaction and code standards that are going to be required to exchange that information. So start implementing that now, because we have about a year, a little over a year, a lot over a year, 2 years, 3 years to get this done. So start the team now, because what we have found over time as payers, having to make sure we've got these APIs that work both payer to payer and payer to patient and patient access, it's more difficult than we think. And so making sure that team is working on it today. That's one on the payer side. On the provider side, I would take an inventory of my payer agreements to determine how many of them fall into the CMS bucket, because they'll be looking for that response within the 72 hours and 7 days, starting in January of 26. And then I would look at what are my state payers. And so if I'm in different states, which of those states have different laws, and then kind of putting together a matrix of comparing those states, because then you need to work with your IT team and your revenue cycle management team on how do we implement those requirements and getting the information in a timely manner so we get our responses back. And if you're in a state that's doing gold carding, what does our IT system need to do? What kind of products do we need to be able to track that utilization and the responses and the percentages so that we're tracking those prior authorization metrics? And then last but not least, just because I'm an attorney, never lose sight of your contract. That contract language in this instance is so important, because you're going to be dealing with different laws as they change. And so making sure you're addressing what are the expectations. So both from a payer perspective, you know what you're going to get and what you're going to send. And from a provider perspective, there's no gotchas at the end of the day. We understand what the prior authorization process will be for that payer.
That's great. Those are all very wise pieces of advice for all of us. And a lot of this is probably coming a little bit sooner than we'd like all to hope, but it'll be here fairly soon enough. Phil, do you want to? I think we want to leave a few minutes at the end for answering any questions that may have come through from the audience. Phil, do you want to kind of provide any of the questions for discussion?
Yeah, happy to. We've got, as expected, a number of great questions. Unfortunately, we won't have time to answer all of them, but as I mentioned earlier, any questions that you pose to us that we don't have time to address today, we'll be sure to follow up with you individually with the email address that you provide to us in your survey. So Matthew has asked a couple of great questions, one of which I'll address here. Matthew asked, would the timeframes and denial reasons, I think that Michelle mentioned earlier, for approval responses be required by CMS for organizational determinations, since these are technically voluntary and not considered prior auths in states like Arkansas that have implemented the gold card law? Michelle or anyone else, do you want to take that question?
I'll start, and then Evan and team, if you guys want to chime in. But I think the focus for CMS's timeframe is just on Medicare Advantage, Medicaid, and the CHIP programs. So to the extent the state law has an exemption or a gold carding process, it wouldn't apply to that payer. And it would be what the Medicare Advantage plan or the CHIP plan or the Medicaid plan has for prior authorization list. That's all that those timeframes are going to apply to from that final rule. The state law provisions about if it's a voluntary submission, it's not required as a prior auth, and it doesn't fall in the definition of a prior auth for that state, then those timeframes wouldn't apply. But the state may also have different timeframes. So the state's timeframes may be 2 business days versus 72 hours. So you look at the state for those other provisions, and that's where the gold carding comes in as well.
Yeah, nothing to add. You actually hit it on the head there, Michelle.
Good. Michelle, thanks so much. Next question from Lisa is a great one. I'll just read it to you. Most of the prior auths that I find are based on outpatient hospital or office. Since we're a pediatric site providing outpatient programs, many times authorizations are processed as outpatient hospital and no authorizations required for those specific codes. This does not line up with the health plan's guidance for claim payments. The claims will deny because we are told no auths required, but one is needed for the claim to pay. How does federal or state federal or states manage medically fragile pediatric populations when there's no guidance that separates their needs from the general population? Anyone want to take that on?
I don't think there's anything that specifically addresses that from a legislative perspective at this point. I would say that from an operational perspective, you see this happening in certain types of procedures more than others, and those are the ones that you're going to want to target for a process review. And if you're trying to submit an auth and you're just getting back from the particular payer that there's no auth required, and they're considering you as an outpatient provider instead of a SNF, then you may want to go back and have a conversation with that provider and say, no, you need to understand that I'm not submitting under X, I'm submitting under Y, and I need this authorization because you are going to deny me on the back end if I don't get it. And then at that point, that conversation needs to probably happen outside of an authorization attempt, get an agreement in place, and then implement the new process once that agreement is in place.
Yeah, I think generally speaking, I think there has been nothing really that I've seen come across, but there has been a theme and a trend for more transparency about what the rules are, the rules of the road. And so this is an example, maybe if I'm interpreting the question correctly, about like site of coverage or site of care issues that are not necessarily addressed the provider professional component of it. And so I think there is some language that is coming out in terms of payers being required to publicly publish and make apparent what the rules of the road are. And that's part of the challenge from a provider perspective. There's a lot of black box and darkness around what exactly are the rules. And so that is another area of, I think, effort and more discussion from a legislative perspective of understanding what the rules of the road are. And the other part of it, as being a PA, the rules are also constantly changing. So that's another part of the challenge that we address and deal with at Valor, is the payer rules are constantly changing. And so there's, I think, some legislation intended to kind of freeze that or have windows where the changes are only allowed during a certain period of time. So.
Good. Thank you, Steve. We'll make this the last question. We've got about 2 minutes left. I promised Beata that I would ask this. Are commercial insurance companies allowed to say that the authorization's not required, but the payment will be based on medical necessity, and they refuse to conduct a medical review?
Evan, did you want to speak?
I was going to say, Michelle, can you?
So I'm going to give you the lawyer answer. It depends. So it depends on your state. If your state says that there has to be some kind of review period, or there has to be some kind of peer-to-peer discussion, it will be decided in your state provisions. So I think in every managed care contract I negotiated talks about the fact that you have to have medically necessary services. And then you go through that review and appeal process if it's denied based on medical necessity. So I would say look at your contract and then look at the state law to see if there are any requirements related to the utilization review and those processes related to denial and appeals.
And I was just going to add, I've seen several organizations, managed care contracting and revenue cycle teams partner based off their denial trends to actually put in language associated to that. So either if no auth was required and that's documented with a reference number or a submission response, electronic response back from the plan, then that's in the system that then identifies like, a peer-to-peer, if claims denied for medical necessity post, a peer-to-peer is required for that review, and it's not considered a reconsideration or your first level of appeal. It's in there. So that's how they're trying to leverage it in a contractual perspective. So just some language to maybe think of. Also, no prepayment denials. That's other contract language that we've seen be implemented that says, you'll pay the claim as it was processed, and then you can come back and do a post-pay review, and audit for medical necessity review with peer-to-peer language and that provision of the contract as well.
A great team to pull together to kind of do exactly what Evan just kind of lined out there. So make sure you have representation from your managed care, rev integrity, patient access, and your denials management team. And between typically those 4 teams, you can create a very robust process, not only from your perspective, but also to help your managed care team go back and negotiate with payers for different contracts and things as well.
Excellent. Well, with that, we are unfortunately out of time. I knew this would go by quickly. I want to thank Michelle, Tim, Evan, and Steve for their insights as subject matter experts today. And most of all, I want to thank those of you who attended today's webinar. I know your time is valuable, so we appreciate you carving out some time to attend today. Just as a quick reminder, when you leave today's webinar, you'll see a very short survey. It's just a few questions. We'd really appreciate your input on today's webinar. And as a reminder, for those of you who do complete the survey, we'd love for you to enter a raffle, a drawing for a $100 Amazon gift card, and also let us know if you'd like any follow-up from Valor. It's totally optional, but we'd be happy to address anything on today's subject or anything else related to prior authorization automation technology. So with that, have a great afternoon, and we will see you again soon. Thanks again, everybody.
Appreciate it.
Bye.
Thank you all.